Hi, my name is Atif Darwish, professor and consultant of obstetrics and gynecology. In this lecture, I'd like to address an important topic in endoscopic surgery, which is miniature hysteroscopic surgery or mini-hysteroscopy. Does it have a role in our modern practice or not? This is a critical issue which should be scientifically discussed. Mini-hysteroscopy or miniature hysteroscopy means that we use small caliber hysteroscope, and this delicate hysteroscope is important because hysteroscope is going through an important station, which is the cervix. So it's suitable to pass through the cervix without causing discomfort, and this is important for office use, particularly for diagnostic purposes, and without admission to the hospital, without anesthesia, with less pain or discomfort, with immediate discharge, rapid return to work, and of course is more economic than admission to the hospital. Also, the mini hysteroscopy is valuable in cases with narrow cervix, and we have a study to compare office hysteroscopy versus blind cervical probing in tight primary cervical stenosis in non-repressed women, and it was proved to be more effective than probing, which may lead to false passages. So the concept of mini hysteroscopy is good and ideal for to overcome the problem of the cervix, whether to be used in office or in cases of tight cervix. And this is more important and more valuable if this procedure is done vaginoscopically, which means without using tenaculum, without using speculum, without cervical manipulations, and this leads less pain, less discomfort, less time, and less trauma to the cervix. So, vaginoscopic office hysteroscopy is ideal to overcome the problems of cervix and to go to the endometrial cavity and to see what's inside, and you can treat what's inside the endometrial cavity. So the concept is ideal and good. And for this purpose, the companies developed and innovated fine and delicate caliber hysteroscopes as low as 2 millimeter telescope to be used for visualization up to 2.9, and the sheath overcoming the loading on the telescope can be 3.2 millimeter, and we know that the uterine sound is 4 millimeters. So we use uterine sound without anesthesia in the office for detection of the direction and length of the uterus. So it is 3.2 up to 4 millimeter caliber. And if we use operative office hysteroscopy, we can use up to 6 millimeter or 18 French outer sheath. So the miniature hysteroscopy is good for diagnostic office hysteroscopy to see what's inside the endometrial cavity. Some doctors have the single port office hysteroscopy. I don't recommend this type because you inject fluid here to distend the endometrial cavity, but there are some blood and debris inside the uterus, so your visualization will be poor and actually takes longer time. So don't buy the single port diagnostic hysteroscopy. It's better to buy dual port inflow and outflow, one to enable inflation or injection of fluid, and the second for suction of the fluid from the cavity. So you should have a miniature suction unit and the pump for injection of fluid, but for office diagnostic procedures, you can use the gravity like this picture or manual compression on the cuff by a cuff of blood pressure sphygmomanometer or any cuff to make pressure to inflate the endometrial cavity. And you should have a camera, of course, and light source. So for office hysteroscopy, you need just camera, just light source, bump or cuff for infusion of fluid, and the telescope and the sheath. And of course, it's very valuable for diagnosing many diseases, and we use it in fertility patients and for tubal patency and breast cells detection, and of course, in abnormal uterine bleeding, searching for a cause of abnormal uterine bleeding. All these are some of our publications. But we can advance the concept of miniature hysteroscopy to do operations. And to do operations, you should have an operative sheath, mini-resectoscopy, or mini-shaver. So to do operative office hysteroscopy, you should have one of these three instruments to do the operations. The operative sheath with side channel, which is bridge with working channel, you can insert through it scissors, graspers, electrodes to do operations. So you should have a side channel. So if you buy one sheath, I advise you not to buy the dual diagnostic sheath. You can use the operative sheath, which is dual plus a side channel for insertion of 5 French instruments. So you can do uh, some small or some operations that can be done easily in the office, like cutting of fine adhesions or cutting of a small polyp or something like this. So if you buy one sheath, it's better to buy dual plus operative sheath, which is operative channel. And of course, you should buy the telescope, the light cable, and the other parts as I already mentioned. So we can insert an instrument through the 5 French side channel like scissors, grasping forceps, electrodes, to cut adhesions, some VersaPoint, which is bipolar gynecare instrument like twizzle, spring, or ball. All of these are 5 French equipments for adhesolysis, metroplasty, cutting small septum, polypectomy, and these are or biopsy, and these are indications of the office hysteroscopic surgery. And you can use single-use electrodes, and this is more expensive. It's not durable. It's fine tip electrodes or reusable cold loops. They are not connected to diathermy, and they are used. You can use as a mechanical instrument to separate myoma or polyp or some adhesions, and of course the bridge to insert the electrodes through it, which is 5 mm, as already mentioned. Some instruments are developed with a possibility of diagnostic and operative at the same time, simultaneously, which means that you start by diagnostic office hysteroscopy, and if you find any lesion, you can change it directly to operative office hysteroscopy, and this is called the two-key hysteroscopic system. You insert telescope 2 mm, outer sheath 2.9 mm, and inner sheath with a side channel 5 French, which is 1.3 mm. And you can start by the diagnostic sheath. And if you find any lesion, you extend it to go with operative sheath and start to do the operations at the same time. As I told you, the operative office hysteroscopy requires either operative sheath, mini-resectoscopy, or mini-shaper. Mini-resectoscopy is a resectoscope, but of small caliber. Usually, we know that active resectoscopes are not used in gynecology. They are designed for urology. We are using passive, which means that the electrode comes towards you to avoid perforation and injury of the uterus. And according to the energy modality, it may be monopolar using glycine or other electrolyte-free media, or bipolar using saline or cold loop without energy at all. And according to the caliber, the standard is around 26 to 27 French, while the mini is 15 to 16 French, which is 5 to 6 millimeter. Of course, the mini resectoscopy is a promising resectoscope and can be used for office with local anesthesia, paracervical block, or without anesthesia sometimes. But it can be used also in operating room. And the receptoscope is composed of a working element, inner and outer sheath, loops and calipers in addition to the telescope. The mini-hysteroscopy or mini-resectoscopy allows a small caliber instrument, which is 15 millimeter or 15 French or 16 French, to be used for office procedures. And there is a plasma edge mini-resectoscopy, Lamidi Nuri resectoscope, and there is a lecture on this instrument in this channel also. Or Gubini, which is a common and famous mini-resectoscopy. And this is the video on plasma edge mini-resectoscopy. The advantages of mini-resectoscopy or plasma edge saves time and money, no admission, wide varieties of indications, precise cutting of the base, supplies adequate tissue for biopsy. Loop shape can be changed according to the site of the lesion with precise edge due to plasma, no thermal burn or distribution of energy. Of course, it saves money, time, and suitable for polypectomy, thick endometrium, myomectomy, metroplasty, removal of products of conception, niche surgery, or ectopic scar pregnancy. And for myoma, some studies found it's helpful for 0 and 1 types, and of course, type 2 is not highly indicated. The third and last type of operative office hysteroscope is mini-shaver. And mini-shaver is a mechanical instrument, actually, and you insert the parts of the two hollow metal tubes inside the uterus. Does not need high experience and is connected to motor with a pump for suction, and you can use it to remove polyp, myoma, or any intrauterine lesion like products of conception and so on, using this mechanical shaver. And there are many types of the classic or standard like Bugatti or Myosure or otherwise, but there is innovation of miniature shaver, 6.3 millimeter intrauterine Bugatti shaver. The resectoscope is advantageous over other methods. Why? Because it's possible to use it for adhesiolysis for septum, vaginal septum, endometrial ablation, endomyometrial ablation, in addition to myoma and polyp. But the alternative, which is like shaver, can be used for myoma or polyp and less, but it has the advantage of less operative time and more safe. So this is the miniaturization of hysteroscopic surgery. Now in my practice, should I go to miniature office hysteroscopy or to stick to the standard hysteroscopic surgery? So what are the disadvantages of office hysteroscopic surgery? As I already mentioned to you, office hysteroscopy, particularly vaginoscopic approach, is good and optimal for diagnostic purposes in your clinic to diagnose the cause of bleeding, cause of infertility, and to check if the patient has polyp, fine adhesions, or otherwise. But doing advanced surgery in the office, in your clinic, without any control, without anesthesia, is a point that should be discussed deeply. We have to know that the advanced technology and innovations allowed medical companies to innovate these telescopes of 2 millimeter caliber and sheath of 2.9 millimeter or up to 3.4 millimeters. So this innovation of fine mini hysteroscopy allowed them to start to promote it in a commercial way. They focused on some medical centers with well-known names and figures to distribute and to start to make these instruments familiar or popular among gynecologists, and young doctors look to these well-known names and figures that they are the ideal and optimal, and we have to follow them in this point. But we have to know that the patient has a near lifetime risk of developing the lesions. If you ask yourself and the patient who has submucous myoma, how many times she has submucous myoma in her life, you'll find her just once or twice in her life. So a problem that is developing just once in the patient's life should be dealt with in a meticulous and careful way to have the best curative option under the optimal conditions, not to remove a myoma in your office while you are doing the examination in your office, the same bed for examination, the same bed for ultrasound, is not suitable to remove a submucous myoma from a patient who develops this myoma once in her life. This is a point should be put in mind away from the medical equipment companies. And the primary goal of surgery should be to ensure patient satisfaction. Where is the patient? If you decide to do hysteroscopic myomectomy in the office without anesthesia, without admission, in the same place where you are doing ultrasound, when you are doing speculum examination, vaginal examination, where the patient's opinion, where is the patient's right to say no or yes, not to push the patient. Most of these centers push the patients to this approach, aiming at short procedure, no admission, no anesthesia, no, but there is no patient satisfaction with these procedures. And this picture, I took it from a webinar recently done by one of these centers specialized in miniature hysteroscopy, and look to the position of this patient. Who can, male or female, who can accept to be in this inconvenient position for 20 minutes, for 30 minutes, to remove a type, they mentioned type 2 myoma can be removed, to remove a type 2 myoma from the myometrium and make the cold loop to remove a type 2 myoma or type 1 myoma by the mini-resectoscopy. And the patient is waiting for this procedure in this bad situation and bad position. Why to put this patient in an inconvenient position and situation? Why to do this while she's developing myoma just once in her life? And there is a recommendation by the Royal College of Obstetricians and Gynecologists that outpatient hysteroscopy can be associated with significant pain, anxiety, and embarrassment. And this not only impacts upon the satisfaction of the woman with their experience, but also limits the feasibility and the possibility of and safety, accuracy, and effectiveness of the procedure. If the patient is inconvenient or anxious or with pain, and this is very common in our female patients, this may lead to incomplete procedure. You are doing it very fast because of pain, because of inconvenience, very fast, liable to a high rate of complications, incomplete treatment, and ineffective procedure. And this is a recommendation by the Royal College. The more advanced surgery, the more pain. So you have to expect more pain. Why to put your patient in a pain situation? And there is a group of rich ladies who made a campaign against painful hysteroscopy. And this has been made up in UK patients who have had very painful outpatient hysteroscopies and or womb biopsies. and a significant number of UK hysteroscopy patients, up to 1 in 3, will suffer severe pain during these outpatient procedures. And those group of patients mentioned that they need all population, and all societies, and all doctors to help them to end this barbaric hysteroscopies with inadequate pain relief. And this has been signed by over 64,000 ladies who already have this problem and complaint with office hysteroscopic surgery, and they requested uh, good information about the hysteroscopic procedure, including pain, discomfort, inconvenience, safety, and effectiveness of pain relief, a genuine choice of non-anesthesia, local anesthesia, safe monitoring, conscious sedation, epidural, general anesthesia. You have to discuss every point with the patients with advantages and the disadvantage, and she has to choose, not you to push her that this technique is good. Another additional point of technical difficulties, there are some failed cases and some perforations, possible perforations. What to do if you suspect perforation? Just observe the patient in your office while you are examining other patients, or you should do this procedure in a well-equipped place for possibility of emergency laparoscopy to deal with the perforation. If it is big, you have to take stitch. If it is small, you have to aspirate blood and put the patient under observation. There is no intensive care or intermediate care units in your office. This is an important issue, particularly those who are doing type 2 or even type 3 myoma. It's just strange to do this in your examination room. Absent anesthesia control if intolerable pain. If you start after good counseling and the patient is not tolerable to pain, and you cannot give her, you give her sedation, where is the conscious sedation that she needs? A specialized nurse, or where is the anesthesia doctor to give the patient anesthesia to avoid stoppage of the procedure? There is another technical difficulty, which is possibility of incomplete procedure or second session, particularly if there is complications, or if there are complications on anxiety or intolerable pain. The need to remove the chips from the uterus is another important issue. If you make myomectomy, and the chips of the myoma are inside the cavity, and you introduce many resectoscopy or the operative sheaths, and you don't have intrauterine shaver, in such a case, these chips will be retained inside the uterus, and this may lead to pain and discomfort, and may lead to endometritis and even pelvic inflammatory disease. So these points should be put in mind if you are planning to do myomectomy in the office, in your examination room. This should be put in mind, how to remove the chips of the tissues removed. And of course, there are some problems of excessive air bubbles, especially if you have anterior lesions, because they are close. You have to become nearer to the lesion and use suction unit. And again, these are not always available in the office, and is not suitable for complicated or advanced cases like multiple fibroids, type 2 myoma, uterine niche. All these procedures need control. Uterine niche needs ultrasonographic guidance, may need laparoscopic guidance in some cases to know the residual material thickness. And of course, there are some problems with insurance. If you are sending for myomectomy in the office, the insurance will not approve. They usually approve for endoscopic procedures or open procedures. So in conclusion, after discussion of this procedure on the innovation of miniature hysteroscopy is good for office procedure, diagnostic procedures, but for operative procedures is not always successful. And we had a comparative study of office hysteroscopic reconstructive surgery versus conventional day case hysteroscopic reconstructive surgery in our center with 30 years experience in hysteroscopic surgery. And we found that office operative hysteroscopic surgery was successful in only 68% of cases, despite less operative time, less destination media, shorter post-operative stay. But from the patient's point of view, if we have 100 patients, only 68 had succeeded procedure, and around 32% of patients need another session or need day case admission, and they will be not satisfied. But for conventional day case operative hysteroscopic surgery, reconstructive surgery, it was successful in all cases with better visualization in the endometrial cavity, with significantly better patient and doctor satisfaction. So we recommended that it is still a preferred approach. So my advice, if you would like to have office hysteroscopy according to the media, according to the conferences, and so on, so it's good to have office vaginoscopic office hysteroscopy for diagnostic purposes. And you can buy the operative bridge instead of the dual diagnostic sheath to be able to insert a small or a fine 5 mm scissors to cut fine adhesions, small polyp, or minute lesions. And this will be a good achievement or addition to your clinic. But performing advanced surgery in this bad situation of the patients with complaints and discomfort without proper anesthesia actually is not good, and the patient may blame you and may say that you performed to them aggressive procedure without restriction of their pain tolerance, convenience, and actually this is not a good repetition. And we presented such a recommendation to the ASRM meeting in 2013 before as a routine vaginoscopic office hysteroscopy in modern infertility workup. And regarding operative office hysteroscopy, I advise you to make it after good experience for straightforward cases, simple cases that do not take long time, do not need too much anesthesia without pain, discomfort, or inconvenience to your patient after proper pre-procedure counseling. Thank you.